Hi, I really want to talk about a topic that I talk to patients all the time. Should I start hormone replacement therapy? I'm only 35, but I feel all the symptoms of perimenopause, and I want to know if this is right for me. So, this is a discussion I wanted to bring up because this is something that I think is going around the internet. Everyone's being told that they should be on hormones. And I really want to talk about the nuance as a naturopathic doctor, my perspective on this conversation. So, when we look at the first thing we need to understand is we need to frame the question. So, if you truly are no longer producing estrogen, then under the age of 40, it is considered POI, premature ovarian insufficiency, also known as premature menopause. Okay. So, when we're looking at that specific person, we need to make sure this is typically someone who doesn't have a period anymore, they have amenorrhea, and or they have something that has driven them to be in early menopause, whether it's chemotherapy, radiation, or the removal of the ovaries. This is going to put them into menopause. Now, the risk here is actually in not treating, right? Guidelines are unanimous that hormone replacement therapy should be used in these individuals until the average natural age of menopause, at least about 51 or 52. And when we look at the familiar HRT cancer clot warnings, they just don't apply in this window because untreated deficiencies of hormones at this age, at this young age, carries way more risk, cardiovascular consequences, cognitive consequences, and bone issues. Now, if you have normal ovarian function and you've been given hormones for a vague symptom cluster, this is not true replacement. This is where we can have the conversation of, okay, should I be on hormones? Is it right for me? Maybe before the age of 40. And what would indicate that I would need them? And what are the risks of starting early? Because when we really break it down, starting hormone replacement therapy, typically women are starting 45 and up. And a lot of women are starting in their late 40s or maybe early to mid 50s. And the reality comes is staying on hormone replacement therapy is an individualized decision. So it's an individualized decision to start and it's an individualized decision to continue. There is no time frame right now with the guidelines that say you have to stop after this amount of time or you have to stop at X time or X age. And so really conversation is the communication between you and your healthcare provider to determine the risks and benefits at all stages of the game, at every aspect of going through this process. And so the question becomes, what are the risks if hormones can help me at the age of 38, even though I'm not in perimenopause? What are the risks of starting? So that's what I really want to talk about. So here's where I want to start. Because as a naturopathic doctor, I am, trained and well versed in looking at the root cause and looking at what is going on. And a common concept and a common theme that I see with patients is that we tend to blame things on hormones when hormones might not necessarily be the root cause. Because when I look at the way that I provide care to patients, I kind of divide things into 4 pillars of health, if you will. Pillar 1 is hormones. And what I want to understand here is what the hormones are doing and what is getting in the way of them doing their thing. Things that get in the way of hormones doing their thing include nutrient deficiencies, insulin resistance, inflammation, digestive issues, high stress, poor sleep, chronic, overload. If we just look at the environment that we're in these days, we have everything on our shoulders. We are often working, maybe we're moms, maybe we're, doing a bunch of things all at once. And so the age of, 35 plus, we may or may not have to start caring for our parents or doing things for our parents while we're caring for our children. And that compounds as we get older. So we have high stress load, potentially overweight, insulin resistant, inflamed, low vitamin D, low B12, low iron, right? And we see our doctor and we're like, please help me. Are hormones right for you in that scenario? That's the big question. Often they can help, but I want to talk about some of the nuance. So if you are iron deficient, you can have fatigue, brain fog, poor endurance, poor sleep, anxiety. If you have low B12, fatigue, depression, brain fog, right? Vitamin D, if it's low, we know that we have receptors throughout the brain. Low levels can cause low energy, low mood, brain fog. Insulin resistance, We know that insulin resistance causes a ton of issues and it causes chronic inflammation. And so we know that chronic inflammation independently can drive fatigue and cognitive symptoms. So, as a naturopathic doctor, I am inclined to want to test for these things and help the patient get to the root cause. But the question remains, can someone be on hormones and treat the root cause? Like, can we do both? Can we have it both ways? So let's talk about some of the risks. So risk number one is the clotting. We know that estrogen, specifically oral estrogen, increases the risk of clots, okay? So when we look at a VTE or a venous thromboembolism, there is exposure to estrogen and other risk factors. So when we look at someone who is overweight, their odds ratio for a venous thromboembolism was 2.5 times. With obesity alone, it was 3.9 times. Now, if they had oral estrogen alone, it was 4.5 times. This is specific to an overweight patient with oral estrogen. If they had oral estrogen, so basically, if somebody is overweight, their risk of a VTE is 2.5 times, the risk. If they are obese, it's 3.9, okay? If we have an oral estrogen in an overweight person, that goes to 10.2. The odds ratio increases to 10.2. And if we give oral estrogen to somebody who is obese, that odds ratio goes to 20.6. So we know that estrogen and obesity both independently downregulate protein S, which is an anti-clotting factor, which converges on the same clotting pathway. The one thing that did not add to clotting risk on top of BMI was transdermal estrogen. Now, one of the ways that we deliver estrogen when it comes to HRT is through the transdermal mechanism. We put it on the skin so it can be absorbed better. And so what I'm saying here is that adding transdermal estrogen might be a good option in someone who's overweight because this has no increased risk on their clotting. So again, looking at the risk, if we use a transdermal estrogen, which is typically used in HRT, a gel, a patch, a cream in some circumstances, it does not influence risk. The next risk I want to talk about is breast cancer. So interestingly enough, the breast cancer risk we talk about when it comes to HRT is not about the estrogen. It's actually with the progesterone combined with the duration, okay? So basically, what we found is that if we looked at oral estrogen versus topical estrogen, it actually makes little to no difference on breast cancer risk. What matters is the type of progesterone that's paired with it, okay? What we know from research is the oral micronized progesterone, the bioidentical, body-identical progesterone, does come with a lower relative risk of breast cancer. But what we did know from the research when we looked at the large studies was it was the combination of estrogen and progesterone given to women that caused the increased risk of breast cancer over time, okay? So when we looked at estrogen plus oral micronized progesterone, the relative risk was about 1, okay? When we looked at estrogen plus dihydrogesterone, which is a type of a synthetic progestin, the risk was 1.16, so 16% increase. And then if we looked at estrogen and other synthetic progestins, it was 1.69. So we can choose a little bit of a more breast neutral option by choosing oral micronized progesterone and then again reduce that risk of breast cancer. Now, when we look at the risk of breast cancer, it really comes down to the time because when we look at the research, we see that risk starting between 6 and 8 years between 6 and 8 years approximately of being on HRT. And so the question comes back to this 35 to 38-year-old or this person who's under 40 starting HRT. Potentially, this gives them a decade extra, right? If we started at 35 versus 45, we have an extra 10 years of exposure to this additional progesterone. And duration is the factor that significantly increases that risk. And so you have to be mindful about that. What is the patient's baseline risk for breast cancer? And does exposing them to progesterone for another decade additionally make sense in their case? What else is going on behind the scenes? Should we start somewhere else? Should we look at if we can correct some of these other things, insulin resistance, the stress axes, the cortisol response, support the thyroid, look at gut health, look at, etc. Can we make a big enough impact that the hormones can wait? This is part of the individualized decision, right? And then when we make that choice, do we choose an oral micronized progesterone? The reality is we don't really have enough data to say that starting younger changes the risk in any type of way. But the caveat I want to come to here is that when I'm comparing the breast cancer risk, I'm comparing it to someone on no hormones versus someone who starts hormones. The reality is a lot of times these women between the age of 35 and 40 are going to be offered a type of contraception. The thing is, hormone replacement therapy is not a contraception. And so a lot of these women are already on, let's say, the IUD or the combined OCP, right? So if we break this down and we say, okay, 35-year-old feels like crud, and their options are they can either go on a birth control, the doctor's recommending an IUD, or an oral contraceptive. What does that mean, right? We know when we look at being on OCP, or so the pill or the IUD, we're taking a progestogen. We're taking a synthetic progesterone, and that is where the breast cancer risk comes. So when we look at the IUD, the relative risk is 1.2, similar to the combined oral contraceptive pill when it comes to breast cancer risk. And when we looked at the IUD, there were 14 excess breast cancer cases per every 10,000 people over 7 years. So the absolute risk in your 30s is from 0.49% to 0.69%. Now, we know that the combined oral contraceptive would be arguably worse because we're actually giving, so if you were given, okay, well, we can start HRT and we would do a transdermal estrogen and we would layer that on with an oral micronized progesterone, and you were to choose that option, or we can just put you on birth control. You'll have the contraceptive, you'll have the oral contraceptive pill, you'll take a pill each day, that'll be the estrogen and progesterone. Because it's suppressing your ovulation, it will help your symptoms by being a contraceptive. Some people don't feel good on a contraceptive, but that's just the rationale behind it. Arguably, this could be worse because an oral contraceptive is going to be an oral estrogen, which carries that VTE risk, especially if you're over the age of 35 and a smoker. We know that clotting risk goes up. So in that specific argument, the HRT style regimen might be the lower risk option. And you're like, okay, well, hold on. The breast cancer risk is, attributed to the progesterone. So why can't we just go without progesterone? The reality is if you have a uterus, you have to have a progesterone if you have an estrogen because it protects the uterus against excess growth, against the lining getting too thick, okay? When we look at the Mirena, the IUD, the Mirena and HRT, so we can actually use the Mirena IUD. I'm talking about this oral micronized progesterone, but the Mirena IUD specifically can be used off-label as the progesterone component to HRT. So we would give the IUD and then we would give you the estrogen. Now, this can actually serve as the endometrial protection, but it does add or contribute to that breast cancer risk that I already talked about in HRT. So what I'm saying is that if you were already on the hormonal IUD and we're adding estrogen on top for HRT, we're not necessarily changing the risk that you were already, dealing with. Now, when we look at the distinction between the two, is really the dose and kind of how they're delivered. Another risk that comes with HRT is a small, consistent signal of ovarian cancer. Now, that sounds scary. The relative risk is 1.4, even with under 5 years of use. We see this concentrated into the serous and endometrioid subtypes. The absolute risk is small, roughly 1 extra ovarian cancer per 1,000 users over 5 years, starting around age 50. Now, 2 caveats for this matter. The driver is heaviest when we have unopposed estrogen. So we know that having the unopposed estrogen can increase the risk. And essentially all of the data for this risk is on postmenopausal women. So extrapolating decades of exposure from age 35 is actually uncertain. So what we know about oral contraceptive pill is that there is protection against ovarian cancer. This is actually one of the most positive benefits that we see again and again from being on the birth control pill for years and years. And we know that that benefit persists long after stopping. So we know that being on the pill lowers ovarian cancer risk 30 to 50%, and that rises 5% per year of use, reaching about 50% at 10 plus years. So if you're on the pill for about 10 years, your ovarian risk goes down significantly. We also know that the protection actually persists after stopping. So 30 plus years is what we've seen in some data. So again, if we factor this on, if you're like, okay, I started, again, this is a conversation. This is the data. This is a discussion that I think a lot of people don't have. And this is the reason why I wanted to make this video, because it is nuanced. And if we start to look at some of the risks, what we know, what we don't know, if you had 10 years of pill use, you stopped in your 20s, and then you were considering starting HRT at 35, you potentially are entering HRT from a lowered ovarian risk baseline, right? You're carrying that residual protection from the years of OCP. And the mechanisms are independent. And so it's hard to say how much you are actually increasing your risk when we add HRT if you've had that prior protection that we know is durable. So again, this is another piece of the conversation that is worthwhile. And I'm not saying that the risks are significantly higher. What I am saying is that when we start HRT matters. And so if we can do other things, look for other causes, look for other root reasons why something might be going on, this might benefit you in the long term rather than jumping into HRT. But I'm also saying that in an informed consent conversation, this might be a good move if you were going to choose to be on hormones anyway, and you don't necessarily need the contraceptive benefit, but if you do, you could use the IUD. This might benefit you. But this is an individualized discussion and something I see on the internet as a one size fits all. Here's some kind of often forgotten risks. So one of them being melanoma. We know that estrogen only therapy does show a raised risk, relative risk of 1.3. But we do know that estrogen plus a progesterone shows essentially none. And so we actually do see that being on a progesterone or a progestogen, this counteracts the melanocyte stimulation. So again, if you have a uterus, you have to be on progesterone. And so we can mitigate the risk of that unopposed estrogen by just being on a progesterone, which helps the uterus and is required anyways. Another thing is gallbladder disease. We know oral estrogen supersaturates bile with cholesterol. Transdermal doesn't do the same. So this transdermal estrogen can be the route because it reduces that clotting risk and it actually reduces the risk of gallbladder disease. Now, one thing I want to highlight is benign estrogen sensitive conditions. So a 35 to 38-year-old is far likelier than a 55-year-old to have fibroids, endometriosis, and adenomyosis, which are all estrogen driven, able to be stimulated regardless of a route, because whether we do it oral or transdermal, we know that adding estrogen can fuel these things. So, if somebody has a history of endometriosis, heavy painful periods, history of polyps, we want to make sure we're doing a workup before we're just throwing estrogen. And I would say also looking at migraine risk as well. For some people, when the hormones start fluctuating, migraines become worse. And so giving HRT is going to stabilize it because we stabilize the hormones. But for some people, no matter what we do, adding estrogen worsens their migraines. And so we have to be mindful of that as well. Now, autoimmune disease is one of the ones to consider as well. When we look at the data on rheumatoid arthritis, HRT does not increase flares and actually may improve disease activity. When we look at lupus, there is a genuine caution here. There's a small increased risk of mild to moderate flares. And so estrogen needs to be used with care. And then if we look broader, we do know that a large 2024 analysis linked combined estrogen and progesterone therapy to increased risk of several conditions, including Sjogren's, systemic sclerosis, SLE, and others. This is the combined regime. So unlike the melanoma conversation where progesterone was protective, it was not protective here. And so this is important if you have a lot of autoimmune issues in your family to consider this before starting it. And I'm not saying that we rule it out and this is a contraindication to starting at all, but this might be an indication that you want to start closer to 45 or older if you're going to start, for those genuine benefits we see when your hormones are genuinely declining, even though you might benefit symptomatically now. And so, in summary, putting it all together, transdermal estrogen plus an oral micronized progesterone is a low-risk way to deliver hormones. And these are not the same as a contraceptive. They are a lower dose, and so a lot of the risks are lower. We know that transdermal estrogen and a micronized progesterone reduce the risk of clotting, VTEs, gallbladder issues, melanomas, and the endometrial risk. It doesn't neutralize the ovarian signal. This is relatively unstudied, and we don't know over a long duration of time of being on HRT if this is going to significantly increase. We also don't know if somebody was on the pill in their younger years and reduced the ovarian cancer risk, if putting them on HRT earlier still gives them a protective effect to be on for that long. This is unclear. We also know that being on hormones can stimulate existing fibroids or endometriosis, and there is a genuine question of the autoimmune signal. And so, in my opinion, as a naturopathic doctor, I like to start by understanding the hormone landscape. Are you in premature ovarian insufficiency at this point? Because if so, none of that risk matters. And the genuine benefit is that we need to be treating those hormones, with hormones right away. Beyond that, it is an individualized conversation that might benefit some, but is not a blanket recommendation. In my opinion, we correct nutrients, iron, B12, vitamin D. We address insulin resistance and inflammation. We reevaluate our cortisol load and we look at the thyroid. We do a baseline skin check. We look at inflammatory markers. We look at your autoimmune history. We also know that looking at hormones in a cycling woman can be hard to interpret. It does not establish a deficiency, but looking at your hormones over a few months might be really helpful. And after we can correct some of these pieces, we can reassess. And if there is a genuine hormonal gap that we cannot fill, then adding a transdermal estrogen and an oral micronized progesterone or an IUD could be a really good option moving forward.